Okay, hello everyone. I think it's almost the time. So on behalf of Professor Dong-Soo Lee, I'd like to introduce our first lecturer for our 2021 first semester lecture series. So Dr. Hae-Ju Son is currently the professor in Department of Nuclear Medicine in Dankook University Hospital. She had residency training in Donghua University and fellowship training in Asan Medical Center. Her main research interest is neuroimaging of Alzheimer's disease and Parkinson's disease. So today, Dr. Son will deliver us a lecture regarding nuclear imaging for Parkinson's disease. So please welcome Dr. Hae-Ju Son. Thank you.
Thank you for the introduction. Today, I will talk about the nuclear neuroimaging in the Parkinson's disease, especially in clinical pathology and imaging diagnosis of Parkinson's disease. First, clinical feature of Parkinson's disease. Okay, before the start, close your eye and imagine your loving grandpa get diagnosed with Parkinson's disease. Maybe at the first time, he may complain of impairment of dexterity in using hand, problems of using keyboard that keeps typing a letter twice or change in the writing. Because the onset is so gradual and the early symptom might be unnoticed or misinterpreted as rheumatism or just a normal aging problem. After several years passed, family member might notice that his face is expressionless, speech is monotonous, and posture is flexed simian with peer rolling tremor of the hands. The classical motor symptoms of Parkinson include bradykinesia, muscular rigidity, and peer rolling rest tremor, 4 to 6 cycles per second, and postural and gait impairment. The diagnosis of Parkinson's disease cannot be made without the detection of bradykinesia, although individual exists with monosymptomatic rest tremor who have abnormality of striatal dopamine functional imaging. Two subtypes of PD include PIGD-PD, which is main symptom is postural instability and gait difficulty. With the ventrolateral side is degeneration in substantia nigra and showing poor prognosis and rapid progression. The other type is tremor dominant PD with medial substantia nigra degeneration showing relatively good prognosis. Main known risk factor of PD is aging. Onset of late onset PD is over age 16 and onset of young onset PD is 20 to 40 with predisposing susceptibility genetic mutation such as alpha-synuclein or leucine rich repeat kinase 2. This is VMAT2 and DAT binding over the course of Parkinson's disease. Loss of dopamine markers in Parkinson's disease follows exponential decline. Decline is most rapid in the early stages and eventually approaches in the plateau. There is a differential involvement such that the posterior putamen is more affected than anterior putamen, and this difference is maintained over the course of the illness. At symptom onset, the loss of putamen DTBG binding was substantially greater in EUPD, but the rate of progression of DTBG binding loss was slower in EUPD. The estimated pre-symptomatic phase of the disease spanned more than 2 decades in EUPD compared to 1 decade in LOPD. Compared to LOPD, EUPD progresses more slowly and are able to endure more damage to the dopaminergic system before the first motor symptom appear, suggesting EUPD has more efficient compensatory mechanisms. This is clinical symptom and time course of Parkinson's disease progression. Diagnosis of Parkinson's disease occur at the onset of typical motor symptoms such as bradykinesia and rigidity at the time 0 years point on the red bar here. But the clinical onset can be preceded by long premotor or prodromal phase of more than 20 years. This prodromal phase is characterized by specific non-motor symptoms such as impaired olfaction, constipation, or depressions. At the later stage, axial motor symptoms such as postural instability with frequent falls and freezing of gait tend to occur in advanced stages. Non-motor symptom occurring at later stage is dementia. Now I will talk about pathology of PD. Two distinctive pathological hallmarks is selective degeneration of dopaminergic neuron in pars compacta of substantia nigra, particularly in the ventral lateral tier, and accumulation of alpha-synuclein in Lewy body and neurites. Neuronal loss in the substantia nigra alone can also be found in other non-alpha-synucleinopathies, such as primary tauopathies, including PSP, CBD. Why dopaminergic neurons are selectively lost in the PD brain? The study published in Nature Medicine suggested a potential mechanism for the dopamine-dependent neurotoxicity of alpha-synuclein in PD brain. Alpha-synuclein in cultured human dopaminergic neuron results in apoptosis that requires endogenous dopamine production and mediated by reactive oxygen species. In contrast, alpha-synuclein is not toxic in non-dopaminergic human cortical neuron, but rather exhibit neuroprotective pathway. This is spatial and temporal spreading pattern of various neurodegeneration. According to the Borak staging of Lewy body pathology in PD, progression of alpha-synuclein Lewy pathology in PD follows the ascending pattern from the brainstem to the telencephalon. The earliest region can be detected in olfactory bulb, explaining anosmia is prodromal symptom of PD, as well as dorsal motor nucleus of vagus nerve in the medulla oblongata. At the later stage, alpha-synuclein aggregate pathology is found more rostrally through the brainstem via pons midbrain in the basal forebrain and ultimately in the neocortex. Substantia nigra of midbrain and stratum, thalamus, and primary motor cortex is somatotopically organized through the motor circuit loop. This is neuronal loss in postmortem brain of substantia nigra in normal aging, Parkinson disease, PSP, and MSA. PD-associated loss of dopaminergic neuron has characteristic topology distinct from the pattern seen in normal aging. In PD, cell loss is concentrated in the ventral, lateral, and caudal portion of substantia nigra, whereas during normal aging, dorsal medial aspect of substantia nigra is affected. MSA showed almost identical topography with PD, and PSP showed even and extensive degeneration involving all regions of the midbrain. Left side is normal nigrostriatal pathway. It is composed of dopaminergic neurons whose cell bodies are located in substantia nigra pars compacta, projecting to the basal ganglia and synapse in striatum. Right side is diseased nigrostriatal pathway in PD. PD-associated loss of dopaminergic neuron has a characteristic topology distinctive from the pattern seen in normal aging. In PD, cell loss is concentrated in ventrolateral and caudal portion of substantia nigra. I will talk about PD-associated cognitive impairment. This is Diagnostic Procedure Movement Disorder Society, PD with dementia criteria. Establishing the diagnosis of PDD is important for the management of patients and their caregivers, including personalized care needed. The main feature of clinical PDD criteria is incidence decline in more than one cognitive domain that is severe enough to impair daily life and lasting for at least 6 months. All patients with PDD have alpha-synuclein Lewy body pathology, particularly in medial temporal lobe region shown in panel A, but over time, there is an increase in neocortical and subcortical Lewy-related pathology. Approximately 50% of PDD patients have beta amyloid plaque in the cortex, which are indicative of pathological changes of AD. 2/3 of these patients also have phosphorylated tau deposition in cortical tangle, indicative of AD. Cognitive spectrum and heterogeneity of progression of cognitive impairment in PD. Cognitive changes, mostly in the form of subjective cognitive decline or MCI, can occur prior to or at the time of PD diagnosis, or even decades later, with high variability in the rate of progression and its clinical severity. Cognitive fluctuation may also occur, in which, for example, some patients with a PD MCI may revert to normal cognition and then developing cognitive impairment later in disease course, typically accompanied by motor progression and the occurrence of other non-motor symptoms. Neurotransmitter deficits associated with cognitive decline in PD and the DLB. The dopaminergic deficit is widespread initially in the caudate nucleus in PD with mild cognitive impairment, later progressing to limbic and neocortical brain region in PDD. Dopaminergic deficits are usually more restricted and less severe in dementia with Lewy body. Similar to dopamine, deficit in noradrenaline occur in brain in PD with normal cognition, but widespread noradrenaline deficits are progressively found in increasing severity of cognitive impairment in PD. Similarly, there are widespread cholinergic deficit in PD with normal cognition, but increasing deficit targeting the hippocampus occur with the increasing severity of cognitive decline in PD. So this is a hypothetical disease course of preclinical Parkinson disease. The red line is pathological degeneration of dopaminergic neuron, and the blue line is clinical rating. Preclinical PD can be defined as the state that precedes the onset of the characteristic motor feature of PD, possible PD. Loss of dopaminergic neurons develops slowly and gradually progresses over years during preclinical stages. Before cardiac motor symptom of PD appear, several premotor symptoms are present during premotor stages. Some non-motor feature may be present or subclinical abnormality may exist that can be detected only by neuroimaging or by biological test results. Okay, next I will talk about the main topic of this lecture, nuclear neuroimaging biomarker of PD. A variety of potential biomarkers for diagnosis of PD are currently under investigations. This biomarker can be classified as clinical, imaging such as PET, MRI, transcranial sonography, MIBG cardiac imaging, or pathologic biomarker, genetic biomarker. Combinations of these biomarkers are likely to be necessary for accurate diagnosis of premotor or early PD. For imaging, the main target is basal ganglia involved in dopaminergic signaling pathway. This is three-dimensional representations of the sensory motor, which is green color, association, pink and purple color, and limbic territory, which is yellow color of the basal ganglia, superimposed in T1 MRI image. More specifically, striatum is just a look-like rabbit. It can be subdivided in the caudate, anterior caudate, and posterior caudate. And the face of the rabbit is ventral striatum, and body of the rabbit is putamen, divided into anterior putamen, posterior putamen, and foot of the rabbit is ventral putamen. This is dopaminergic nerve terminal labeled by radio tracers. Fluorodopa is decarboxylated to dopamine and stored in synaptic vesicle in a manner analogous to levodopa medications. The vesicular monoamine transporter type 2, VMAT2, is labeled by C11-DTBG, and the membrane dopamine transporter DAT can be labeled by C11 methylphenidate or various other agents suitable for PET or SPECT labeling. Dopamine D2 receptor availability can be labeled by C11 raclopride, which is sensitive to synaptic level of dopamine. There are various molecular imaging options for the patients with PD. Various PET and SPECT imaging techniques have revealed the PD-associated alteration in dopa decarboxylase activity, dopamine transporter availability, noradrenaline transporter, dopamine D2 or D3 receptor, VMAT2, vascular monoamine transporter activity, or serotonin transporter activity, acetylcholine or opioid activity, and glucose metabolism. Advantage of dopaminergic imaging is usefulness for the differentiation of PD from disorders without presynaptic dopaminergic terminal deficiency, such as essential tremor or vascular Parkinsonism. There are various approaches to the assessment of integrity of dopaminergic nerve terminal. Upper row is PET images from healthy control, and lower row is images from Parkinson's disease. In keeping with the distribution of Negral cell loss and with postmortem neurochemical studies of Parkinson's disease, all tracers of presynaptic dopamine function show the characteristic pattern of asymmetric reduction in trace uptake that affect the posterior striatum more than anterior. Uptake of tracer is abnormal in the clinically unaffected striatum in Hoenya stage 1. And reduction in tracer uptake correlate with degree of the motor dysfunction, such as bradykinesia. Such dopaminergic imaging can be used for differential diagnosis between normal and idiopathic Parkinson's disease, as well as between PD and atypical Parkinsonism, and for tracking disease progression. In the fluorodopa PET, radio-labeled fluorodopa is decarboxylated to fluoroating fluorodopamine, and the activity is trapped in the synaptic vesicle. It can estimate dopamine turnover with prolonged scan time. Activity can be increased relative to degree of denervations in early disease, possibly due to the compensatory upregulation decarboxylase activity. This is example of fluorodopa path. Fluorodopa uptake will reflect the clinical severity as well as disease progression. Vesicular monoamine transporter type 2 is labeled with C11 DTBG or F18 DTBG, but it is not specific for dopamine, rather expressed by all monoaminergic neurons. Most of binding stratum is to dopamine nerve terminals. Theoretically, it is less subject to compensation and regulatory change than other tracers, therefore, more give a good quantitative estimate of nerve terminal density. This is example of vesicular monoamine transporter type 2, DTBG of normal control and PD. For the dopamine receptor, most studies are done with regard for dopamine D2 or D3 receptor. It can estimate dopamine release by use of the ligand with relatively weaker affinity for D2 receptor because binding subject to competition from endogenous dopamine. Higher affinity ligand used to assess extrastriatal D2 binding. This is example of D2-D3 dopamine receptor imaging, Lacropride and IBGM. PD showed preservation of postsynaptic receptor. Dopamine transporter can be measured with variety of C11 or F18 PET tracer or iodine 123 or technetium SPECT tracer. It has selectivity for DAT versus other monoamine transporters, and kinetic properties varies between tracers. DAT activity is theoretically subject to pharmacological regulation and compensatory downregulation. This is list of the drug which can affecting presynaptic dopamine transporter binding. Effect of methylphenidate severely reduced CIT uptake, which will reverse in the follow-up scan if stopping medication. However, for routinely used levodopa, dopamine agonist, COMT, and MAO inhibitor, you do not have to stop these drugs before the dopamine transporter imaging. This is SPECT imaging for dopamine transporter, iodine 123, FTCIT, and technetium-based TRODAP. Among various PET and SPECT tracers, FPCIT PET is widely used in clinical practice in Korean and European hospitals and was known to be suitable for PET neuroimaging. Benefit from high selectivity to dopamine transporter, fast kinetics, and excellent spatial resolutions. Moreover, the quantitative outcome measure of FPCIT PET is reproducible with low variability in both PD and ET. Typical imaging find of early PD is asymmetry between right and the left striatum and the antero-posterior dorsoventral gradient. It means impaired dopaminergic function in posterior putamen and relative preservation of caudate nucleus, therefore resulting in increased caudate to putamen ratio. So in the clinical interpretation, we evaluate both axial and coronal views to assess antero-posterior and the dorsoventral gradients. And another TB is preservation of postsynaptic receptor and metabolism in typical PD, which was mentioned in previous slides. Next issue is dopaminergic binding of neuroimaging. Biomarker has been reported to be correlated with the clinical severity of motor symptoms that could be targeted with novel dopaminergic treatment. This figure illustrates VMAT2 specific uptake of healthy control and patients with mild, moderate, and severe PD. Imaging in the healthy control individual revealed symmetric distribution pattern with highest uptake in striatal region and moderate uptake in substantia nigra, lappe, hippocampus, amygdala, and hypothalamus. This figure illustrated the scatter plot and fitted exponential curve of bilateral posterior putamen SUVR against each subscore of UPDRS motor score for postural instability and gait disturbance, akinesia, rigidity, and tremor. All were with a significant exponential correlation except for tremor with SUVR. Other fluorodopa PET study has shown that severity of bradykinesia and rigidity score showed good correlation with levodopa good correlation with fluorodopa binding, although tremor did not show significant correlation. Tremor is one of the most challenging symptoms to manage in the clinic as it has poor and unpredictable response to dopaminergic treatment. Evidence is mounting that tremor may not be related to dopaminergic dysfunction. But tremor is commonly observed in patients with PD and essential tremor. Unlike patients with PD, which shows resting tremor, patients with essential tremor, ET, usually show postural tremor, but some ET patients have overlapping symptoms mistaken for PD and receive anti-Parkinson treatment, unfortunately. Other DAT study investigated the role of DAT imaging to select potential candidates among the patients with ET who are likely to develop PD in the future. This is the example of C11 way 100635 PET study, serotonin receptor binding potential in 51-year-old healthy volunteer and 54-year-old Koenya stage 2 PD patients. In PD, serotonin receptor expression is decreased in the lappe nucleus of the midbrain and cerebral cortex. There was no significant correlation between loss of serotonergic function and bradykinesia or rigidity. However, there was an inverse correlation between serotonin binding in the lappe and resting tremor. In advanced PD, freezing of gait, imbalance, and force are among the most disabling motor symptoms associated with impaired dependence and quality of life. Once developed, these symptoms are usually refractory to treatment with dopaminergic medication. In a PPM-high cohort study of 390 de novo PD patients without freezing of gait at baseline, the degree of baseline DAT uptake of each striatal subregion is associated with the cumulative risk of freezing of gait during the follow-up of 4 years. Levodopa is the most effective drug for the treatment of Parkinson's disease. However, the long-term use of this dopamine drug is complicated by high disabling fluctuation and dyskinesia called levodopa-induced dyskinesia, LID. The different types of LID are shown here. That by diabetic dyskinesia appear at the beginning of the effect of levodopa dosing before full clinical benefit on motor symptom is reached and can reappear when the effect of levodopa start to wear off. Peak dose dyskinesia coincidence with the full anti-Parkinsonian benefit of levodopa on periods, whereas off-period dystonia appear during off-period when levodopa is no longer effective. The risk of developing levodopa-induced dyskinesia depends on both the progression of dopaminergic neurons, degeneration, and exposure to levodopa. As disease progresses, the probability of good clinical response to levodopa decreases, and the risk of both dyskinesia and unsatisfactory clinical response of motor symptom rises. Although preclinical and clinical findings suggest pulsatile stimulation of striatal postsynaptic receptor as a key mechanism underlying levodopa-induced dyskinesia, their pathogenesis is still unclear. In recent years, evidence from animal model or PD has provided important information to understand the effect of specific receptor and post-receptor molecular mechanism underlying the development of dyskinesic movement. Abnormal dyskinesic action of levodopa might reflect maladaptive plastic neuronal effect occurring both at presynaptic and postsynaptic levels. At the presynaptic level, the storage and clearance of striatal dopamine are greatly reduced after severe nigrostriatal region, which might be comparable to the in patients with advanced PD. The degeneration of dopaminergic terminal increases the role of serotonergic terminal in mediating levodopa conversion to dopamine. This is also evidence of an impaired storage and clearance of exogenously derived striatal dopamine associated with impaired monoamine oxidase mediated dopamine degradation, leading to large fluctuation in extracellular dopamine that might then elicit aberrant postsynaptic responses. Two other potentially important presynaptic mechanisms involve endocannabinoid CB1 receptor and metabotropic glutamate receptors expressed in striatal glutamatergic terminals. So in this study, serotonergic mechanism in levodopa-induced dyskinesia development in PD patients was investigated using C11 DASP PET to evaluate serotonin terminal function and C11 raclopride PET to evaluate dopamine release. Clinical evaluation of peak dose LID were assessed using AIMS score, abnormal involuntary movement scale, rating score shown here. They showed that identical levodopa dose induced to markedly higher striatal synaptic dopamine concentration in PD patients with LID compared with the PD patients with stable responses to levodopa. Striatal serotonergic terminal contributed to abnormal levodopa-induced short-term increase in synaptic dopamine levels in PD patients with LID, and the dampening of the activity of this serotonergic terminal via serotonergic agonist drug restored synaptic dopamine to level similar to those observed in PD stable patients and improved levodopa-induced dyskinesia. Presynaptic dopamine depletion can predict future levodopa-induced dyskinesia. Cox proportional hazard model revealed that patients having severe and moderate reduction in dopamine transporter activity in whole putamen as well as anterior and posterior putamen showed high risk for the development of levodopa-induced dyskinesia in the future compared with the mild reduction group, whereas DAT binding in the caudate and ventral striatum was not correlated with development of the future LID. Now I will talk about cortical involvement of Lewy body pathology, which result in various non-motor symptoms of PD. The basal ganglia are divided into motor, associated, and limbic subregion, which are topographically segregated and connected to motor cortex, red color, prefrontal cortex, green color, anterior cingulate cortex, blue color. Specifically, considerable attention has addressed the role of specific topological neuronal circuits mediating the frontal cortex and striatum, which is called the frontostriatal circuit. So we can evaluate striatal dopamine as well as extrastriatal dopamine using imaging. So this is current protocol for dual-phase FPCIT PET-CT. PET imaging were acquired for 10 minutes in three-dimensional 3D mode after 5 to 10 minutes, which is early CIT image, and post-injection 3-hour image, which is delayed CIT image. These protocols enables differential diagnosis between various IPD and atypical Parkinsonism based on the integrated information from early perfusion and delayed dopamine transporter specific binding. This is the diagnostic criteria for PD with dementia. Among various non-motor symptoms, cognitive impairment of PD is very common and can potentially occur at any disease stages. The motor manifestation of PD have been linked to the abnormal spatial covariance pattern involving basal ganglia and the thalamocortical pathway that I previously mentioned. By contrast, little is known about functional network that underlie cognitive dysfunction in this disorder. To identify such cognitive-related pattern, investigators studied non-demented PD patients using FTG PET and voxel-based network modeling approach. This PD-related cognitive pattern, which is called PDCP, identified by spatial covariance analysis of FTG PET scan from 15 PD patients. This pattern revealed metabolic reduction in frontal and parietal association area and relative increase in cerebellar vermis and dentate nuclei. This PD-related cognitive pattern was reproducible and known to be correlated well with performance on test of memory and executive function. Because PDCP pattern is not altered by routine dopaminergic anti-PD medicine, this PDCP pattern may prove useful in clinical trials targeting the progression of non-motor manifestation of PD. The other studies, they investigated disease-related metabolic covariance patterns of FTG PET, allows for highly accurate distinction between idiopathic Parkinson disease and atypical Parkinsonian syndrome, such as MSA, PSP, and CBD. Okay, the last issue of this lecture, I will talk about cardiac MIBG imaging for PD. As you know, Parkinson's disease is a systemic disorder. It's not just a brain disease. With widespread alpha-synuclein pathology in the peripheral and enteric nervous system. Extensive pathology is seen in the parasympathetic and sympathetic nervous system and throughout the gastrointestinal tract. Clinical diagnosed PD and in the prodromal disease phase, functional imaging tools using radioisotope are important for elucidating the nature and chronology of peripheral pathology of PD. Dysphagia, gastric emptying, intestinal transience time, and anorexia dysfunction can also be quantified through the use of radiotracer and radiological imaging techniques. Lewy body disorder is characterized by cytoplasmic inclusion containing alpha-synuclein protein aggregates in the affected neuron. A poorly understood feature of Lewy body disease is loss of sympathetic nerve in the heart and other organs, manifesting clinically as orthostatic hypotension, also postural hypotension. Sympathetic denervation is associated with decreased uptake of catecholamine, such as dopamine and norepinephrine into storage vesicle within sympathetic neuron. This article uses F18 labeled dopamine to track myocardial uptake and retention of catecholamine. In the figure A, this is normal person. Normally, F18 labeled dopamine is taken up by sympathetic nerve via the cell membrane norepinephrine transporter. Cytosolic F18 labeled dopamine mainly undergoes vesicular uptake via the VMAT with subsequent loss of radioactivity via exocytic release, and to the lesser extent undergoes oxidative deamination catalyzed by monoamine oxidase to form F18 labeled DOPAC. Figure B is the reduced sympathetic innervation decreases total neuronal uptake of F18 labeled dopamine, which result in decreased initial myocardial radioactivity. The rate of loss of radioactivity is normal. Figure C, reduced VMAT activity decreases radioactivity because augmented F18 labeled DOPAC production accelerate loss of cytosolic F18 labeled dopamine. Figure D, the combination of decreased sympathetic innervation and reduced VMAT activity decreases initial radioactivity, accelerates its loss, and increases DOPAC production. The fact that dopamine is the immediate chemical precursor for norepinephrine reinforces the view that loss of catecholinergic neuron is fundamental in PD. Herein, the pathological evidence for cardiac sympathetic dysfunction in Parkinson's disease. The investigator examined the left ventricular anterior wall from postmortem specimen of PD and the normal control with the immunohistochemical staining for tyrosine hydroxylase, TH, and neurofilament, NF, and S100 protein, which those are markers for sympathetic axons. In PD, tyrosine hydroxylase, neurofilament, and myelin basic protein immunoreactive axons are markedly decreased in number and the morphological degenerations of cardiac sympathetic nerve. So iodine 123 MIBG cardiac scintigraphy is a sensitive tool for detecting myocardial post-ganglionic sympathetic dysfunction in PD. This case presents longitudinal and serial striatal F-DOPA brain PET and cardiac fluoro-18 labeled dopamine and ammonia or perfusion scan in a PD patients with pure autonomic failure. At the baseline evaluation, cardiac fluoro-18 labeled F-dopamine uptake is already decreased, although brain striatal fluorodopa uptake is still maintained. 2 years later, patients had a subtle decrease in putamen, F-dopa-derived radioactivity, and reported clinically visual hallucination. And at the 4 years later, patients showed clearly decreased F-dopa uptake and clinically complained dementia, but patient did not complain any Parkinsonism yet. These cases illustrate cardiac sympathetic noradrenergic denervation happens several years before development of Parkinsonism or neuroimaging evidence of striatal dopaminergic regions. HER2 mediastinal ratio and regional uptake pattern of cardiac MIBG scan is more sensitive tool than standard autonomic testing or clinical symptom for detection, cardiac sympathetic denervation in PD. When analyzing MIBG myocardial uptake in 8 non-dysautonomia PD group in comparison with 10 dysautonomia PD group, and 10 MSA patients, HER2 mediastinal ratio of both non-dysautonomia PD and dysautonomia PD were significantly lower than in MSA patients. Moreover, dysautonomia PD showed lower cardiac MIBG uptake than non-dysautonomia PD. Lewy body disease include PD, pure autonomic failure, PAF, and dementia with Lewy body. And majority of MSA are non-Lewy body form of alpha-synucleinopathy that involves alpha-synuclein deposition in glial cytoplasmic inclusions, although some minority of MSA patients still have Lewy body. Cardiac ammonia and F18 labeled dopamine PET show that absence of myocardia fluoro labeled dopamine derived radioactivity in the pure autonomic failure and PD patients and normal radioactivity in the MSA patients. So the combination of pre and post-synaptic nigrostriatal neuronal degeneration and sympathetic cardiac innervation using FVCIT for presynaptic dopamine transporter and IBGM for postsynaptic dopamine receptor and MIBG can help the differential diagnosis of PD and atypical Parkinsonism. In the data, there was decreased presynaptic FVCIT binding in both PD and atypical Parkinsonism. Shown here, both is decreased, but in PD, which is upper low, D2 dopamine receptor density is maintained or even increased, and cardiac MIBG uptake is severely decreased. Although in the atypical Parkinsonism, in the lower low, D2 receptor density is reduced and cardiac MIBG uptake is maintained. Okay, my lecture is over. Thank you for listening. Thank you.
Thank you, Dr. Son, for your wonderful lecture. If you have any kind of questions or comments, I think you can just really ask us, or you can write down at the chat so we can have some discussion about it. Just before, I'm a brief questions that, as I know, there is some change in the diagnostic concept for Alzheimer's disease. Like there is some trend moving on to be like biomarkers are getting important, and like not only by the clinical symptoms or symptom-based diagnosis are now changing to the biomarker-based diagnosis in Alzheimer's disease, as I know. Is there some change in trends and also like in Parkinson's disease or related disorders?
Can I again, please?
So like biomarkers are getting important in the diagnosis of Alzheimer's disease. Mm-hmm. So is there also similar trend in Parkinson's disease? So not only like symptom-based diagnosis, but also changing to the biomarker-based diagnosis. So is there such a trend changing also in Parkinson's disease?
Okay, for that questions, I will talk with this slide. Yeah, so the current trend of biomarker for the diagnosis of Parkinson's disease focuses on the preclinical. The preclinical stage was defined not just 3 or 4 years before diagnosis. Very extremely preclinical stage include prenatal stage, which is genetic testing. So the previous biomarker for PD is focused on structural degenerations such as MRI and the clinical diagnosis, which can detect only clinical PD. But currently, various kind of biomarker is developed for the very sensitive early sign of non-motor preclinical clue for the PD, which include not just the traditional biomarker, just saliva, urine, various kind of biofluid. And the other trend is in the previously, we only focused the brain, but currently we see Parkinson's disease as the whole body systemic disease. So more biomarkers focusing on the autonomic and the gut, heart, and peripheral nerve is investigated now.
Thank you. Would there be other questions or comments? Okay, if there's not, thank you again, Dr. Son. And I think after a 10-minute break, I think we can move on to the next lecturer, Professor Jae-Seung Kim. Thank you very much.
Thank you.